I'm Manish. I'm going to be discussing a Conus selective dorsal rhizotomy at L1. Patient selection for rhizotomy involves children with cerebral palsy of clonus and spasticity, minimal dystonia, and they haven't had too many soft tissue releases by the orthopedic surgeons to prevent overextension after rhizotomy. Critical imaging finding is periventricular leukomalacia. Tells us that the child will respond well to selective dorsal rhizotomy. It's critical to localize L1. We use a combination of MRI and fluoroscopy in the operating room. Here you see on the left hand fluoroscope guiding us to L1, and on the right you see that the conus terminates around the body of L1. So we do this procedure in the prone position, perform an L1 laminectomy, open the dura widely. The first step is to do a wide arachnoid dissection on the first side. Here we'll be doing it on the right side. It's critical to do a wide arachnoid dissection here to expose the nerve root bundle on the right. So here we'll be separating the dorsal root bundle. So we're placing a cotton on top of the ventral roots here. After we've identified the exiting L1 root, and then we have L2 through S5 roots. Now we're going to identify the medial boundary, S345. So because of our wide arachnoid dissection, we can find the midline, we find the conus, and then we see the tiny roots that are S3, 4, and 5. We exclude those from our testing and cutting bundle. Next, we're going to identify and split a root bundle. So first we start out with L2. So we're going to split that using a pick or some kind of rodent dissector into 3 bundles. Next, we're going to test and cut rootlets according to our paradigm. Here at L2, we'll employ our testing paradigm. So we induce tetany, record that threshold. If the threshold is below 2, we've gotten an inadvertent ventral root and we set that aside. As long as it's above that threshold, we have a dorsal root. And we compare the first rootlet to every subsequent rootlet, whatever has the highest grade from 0 through 4. We cut the rootlet with the higher grade and preserve the lower grade. By doing so, we cut somewhere between 67 to 75% of the rootlets and spare the 25 to 33% least spastic, depending on the paradigm of your institution. We'll march from L2 all the way over to L5 and S1, which have the large bundles. S2 is a bit of a buffer root, is the option including S1, and then after that we do the other side, and then we move on to a watertight dural closure. It's a critically important part of the procedure to prevent CSF leaks afterwards. A watertight closure here is confirmed with the Valsalva maneuver.